Okay, so what I'd like to do is just introduce Judith Kempton-Webb. Judith is going to be presenting this session. The session is being recorded. We also have on the line some of our point of care team, so you can be asking them questions at the end as well. And I'm going to get Judy to introduce herself, though she has a wealth of experience in the pre-analytical area and a number of titles to her name in terms of her experience over the course of time. So Judith, I'm going to hand it over to you to actually introduce yourself.
Oh, great. Thank you, everybody, for dialing in. Yes, my role with New South Wales Health Pathology currently is pre and post analytical clinical stream lead, so it's a statewide role where we are making improvements in that space of pre and post, which is such a huge part of pathology. Previously, I have a scientific background, and previously I was in the core laboratories and main high throughput laboratories at the John Hunter Hospital. So I've been on both sides, both in the analytical area of the business and now in the pre and post analytical area. I don't profess to have huge experience in the point of care space, so I'm glad we've got some of the experts online if there's any sticky questions around that. But because point of care is a pathology test and is collected as any other collection, it's important that we consider it in the same way, and the pre and post is, particularly the pre-analytical component of that process, is so critical to the results. Welcome, Karen. Okay, so I'll just go back one.
Oh, sorry.
But for today's session, the objectives are really to define the different phases in point of care testing and identify where the highest risk of error sits in that process, to describe strategies to minimise pre-analytical error, and to explain methods to ensure safe practices for point of care testing. And what role does pathology have? Well, pathology is a way to provide patient care, and when we are asked to do pathology testing, whether it be point of care or through the pathology laboratory, 70% of those results are actually used to make decisions and diagnosis of our patients in our care. So pathology results, if compromised, can lead to misdiagnosis, the wrong diagnosis, or delayed diagnosis. So it's really important that we get the right results and that sample is not compromised for testing. Okay, and here's our first polling question, and it's really, where do you think the most common point of care error sits in that process? Is it identification? Is it a poor sample technique? Deviation from analytical procedure? Improper device? Lack of recording results? Or safety, hand hygiene? And someone has voted on the system, and if you don't want to vote using those links, you can use the chat room just to understand what people think is the most important error that we see, the most common error that we see in point of care.
So you can text 0427 541 357 and just text the name Julie Monarchs 147 and then put in the answer. You can use pollingev.com or you can use the chat room. So give it a go. Let us know what you think is actually the most common point of care error.
So we've got a B and an A that's come in on the chat room. So at the moment our patient identification seems to be just in front.
Oh, okay, so we've got 67 have a B. Good. 33 with an A. 50. Oh, gosh, guys.
Well done.
Well done.
You're far more interactive than the last group.
That's right. Well, it takes a bit of time getting used to this, but if we start using it over and over, it should hopefully people get used to it. But okay, so that's interesting. So we've got 25% are saying patient identification. Poor sample for 50% of the group that have voted, and deviation from analytical procedures, 25. I guess they're all relevant in one shape or form, but you're going to tell everyone which is the
Yeah,
key
no, I
top
think someone
one.
has moved their C to a B.
That's okay, guys. You can do that.
So the people that are sitting in the 25% and have selected A have actually chosen the correct result. The most common error in POCT is actually that patient identification part of the procedure.
And funnily enough, followed by the other one.
And the next, yes, that's right. And B does come in second, but it's actually in reverse there.
Okay.
Yeah, thank you for taking part. That's great. So this is some local data that was collected in a project that was run over the last 12 months, and it really highlights that what we are reading in some of the papers and journals internationally is reflected locally as well. In the period between the 1st of January and 31st of January last year, it was identified that there was quite a mix of situations that occurred due to incorrect identification of patients. And in that were 18 wrong blood in tubes where patient A was actually collected instead of patient B and labelled patient B. So there was a switch around, and that in that population of patients, at 831 plus the 18 were cancelled tests due to patient ID issues. And during the survey of patients and staff, it highlighted some inconsistencies between what was reported as an ordinary practice and what patients were experiencing. And the patients made comments that often they were not asked to identify themselves. There were no identifying details in 1 in 4 patients. And 36% of staff reported using patient bed assignment boards or records rather than actually saying to the patient, what is your name? So it really highlighted that it's quite consistent locally as well as internationally, and you can see there that the cost for a recollection and the impact on ED and laboratory staff is quite considerable. And this is supported, this was in the British Medical Journal, I think 2016, and it was quite a number of patients, big patient study, but in that 7,600 wrong patient events were identified, and 9% of those misidentified events led to harm, and a lot of those were actually serious adverse events for the patients. And as you can see in those 4 examples, they range from a patient being resuscitated that in fact had asked not to be resuscitated, a patient that was bought the wrong meal and had an allergy that almost caused him to choke, and also wrong medications and wrong breast milk delivered to a baby from a patient that actually had hepatitis. So all of those were critical events, and all due to the fact that the patient at the time of the procedure, and whether it's a blood procedure or a medical procedure, was not identified correctly. So what is the pre-analytical phase? The pre-analytical phase is everything that occurs prior to analysis, from presenting yourself to the patient, collection, sampling, transport, and processing ready for analysis. And up to 75% of all testing errors occur in this phase. And that's not only for point of care, that is for any of our diagnostic laboratories worldwide. It is a fact that's very well known that the pre-analytical phase or component of that whole of life testing is where most of our errors occur, or 75% of our errors occur, and those pre-analytical errors can definitely cause harm to the patient. So the pre-analytical processes that we're going to talk about today in the point of care space include 4 components. patients and their stability and safety, and obviously that's around patient identification. The sampling and using the correct tube, preparing the site and making sure that the collection procedure is appropriate. And then transport, and transport we think of putting a sample in a car and driving it somewhere else. In the case of point of care, you may be sampling and delivering it to a machine at the bedside, or you may need to walk some distance from the patient and actually deliver it to a laboratory or go to a blood gas analyzer in another part of the hospital. And that's what we refer to transport. And I think the best rule is if you collect the sample in a point of care setting, you analyse it. And the last thing, before you actually present the sample to an instrument, you do have some form of processing, usually, whether it be mixing or something else that you need to do to ensure that the analysis is correct. So we're going to work through those, and I think the most important thing to understand is the pre-analytical errors can often be unknown because the personnel that actually do the interpretation of the clinical results and decide on treatment are not the people that are actually collecting the point of care sample. The setting that you collect these samples in is busy. It's you've got divided focus, you've got a lot of patient complexity, you've got multiple tasks that you're asked to do in the course of your day, and you're not laboratory staff. It's not your core activity. In the laboratory and in the collection space that the pathology departments look after, that's what they do every day, and that's all they do. And people need to be aware that it's not always something that becomes second nature because of the fact that you've got so much to contend with in the space of patient care. And I can only envisage what it must be like, particularly in some of those busy EDs and ICU settings where you have so much. And the training for point of care is just part of the training that you have to receive for so many other tasks that you undertake. So the patient, let's start in that first box and start on the right foot by identifying the patient. ID error frequency in point of care, as we've said, is the highest error that we see in that space. And also in many collection procedures, it's the highest error that we see across national studies. Incorrect or missing patient details on samples are also something that can lead to critical errors. If someone else picks up a blood gas tube or a blood gas syringe or tube and thinks it belongs to someone else, you've just analysed the wrong patient and you have the wrong result sitting in the EMR, which relates to the wrong patient, and then can cause major healthcare issues and can go unreported. If it's undetected in the case of a similar result to the previous, or if there's no previous result, there is no way to know that that result is erroneous or inconsistent with that patient's clinical presentation. So it's really important that you identify the patient. And as we've spoken about, there are consequences of misidentification, and that, as we've said in the previous slides, is the potential harm to the patient, the incorrect treatment, a wrong result being assigned to that patient, and then the anxiety, obviously, of having to recollect or repeat that collection and analysis, and that's the only course of action if it's identified. But as I said, there's many scenarios where that is not picked up and you really don't know that the wrong patient result has gone into the wrong patient records if you have both those patients in the hospital at once. Treatment delay is another consequence, and the anxiety and stress for patients and for the staff who are put under pressure if they're left to look at a result that doesn't fit clinically. and also the anxiety of the patient where they do need to have their bloods recollected. So it's not the best circumstance in anyone's situation. And we've got a scenario here, and this is a true scenario where the samples from two outpatients were collected, and patient A and patient B, and they were labelled B and A. So patient A's blood was labelled with patient B's details. The results indicated that the patient's renal transplant was failing, and obviously that was something that the patient and the clinician didn't want to hear. Luckily, the transplant coordinator realised that it didn't match the clinical picture and had both of those patients repeated. That was a scenario where both the patients did come back, have to have their blood recollected. It obviously wasted time for the patients, the nursing staff and the clinicians, and was extra analysis, which also wastes machine time and reagent costs that are associated. And the incorrect results that were actually sitting in the electronic medical record had to be retrieved and the appropriate changes made. And I think it's really important that the World Health Organization Joint International Commission does state that if you're collecting blood or performing a procedure on a patient, you are responsible for the correct match of the patient with that request. So avoiding identification errors. New South Wales Health Pathology does have a minimum labelling requirement, which really is 2 identifiers, and that can be a full name and date of birth or your medical record number. And we understand that that's not always easy to write on a point of care tube, and certainly with the blood gas syringes, but a sticky label can be stuck on that tube, which ensures that someone else doesn't pick it up and enter the details into the blood gas analyzer for the wrong patient. Also the active ID, and that's a really big thing that we noted in the project that we ran in some of the hospitals locally, that if you don't ask a patient their name and their date of birth, they will just answer yes if you say to them, "Are you Fred Smith?" Because they're in a stressful situation, they're not going to think about the question you're asking. So it's really important to treat that collection procedure just like any other pathology sample collection, and ask the patient what their name and date of birth is. And in the event where you don't have an MRN or the patient's identity is unknown, you can use 99 numbers for entering the details into the blood gas analyzer or into your equipment. It is important that you do use the 9 series, and then you do have to complete the reconciliation form with the correct details and send to your local coordinator or laboratory so that the correct results can be assigned to the correct patient in their records. And I will ask Gail just to jump in if there's anything I've missed as one of the coordinators.
Yeah, look, I think one of the really important things to point out is just to make sure that people are using this 9/9s process and filling in the form and sending it back. It's really important for us to capture that information in the patient's medical record. It might become more important down the track. It's also really important that we use the 9/9s process and not use a date of birth or some other number, as those dates of births can actually match up to other patients within the system. So if you are unable to identify a patient for some particular reason, maybe EMR's down and you can't actually access their information, or you have no idea who the patient is, you can use this unknown process.
Right, thanks, Gail.
Also, I think there is a barcode scanning just for those who find it difficult to type 9/9s in. It makes it a little bit easier if you want to use that. It's on the form and they're in the point of care line group boxes.
Great. And then we move on to the next box, which is sampling. Once you've identified the patient, you need to collect the sample correctly. And potential issues in sample quality can be related to the site selection and making sure that your site selection is correct and that it's treated properly before you do the collection. And again, all of those guidelines sit in that lime green folder.
Mm-hmm.
The source of all.
Yeah, the source of truth.
And common with sample quality problems, now we've moved on from the misidentification, can be broken into 4 groups. Short draw, which is a sample too small in volume, and that's often from using the wrong type of equipment and not filling the tube or syringe to the appropriate level, and that can concentrate the anticoagulant that sits in that tube and also cause issues with the actual testing. Contamination of samples, also a diluted sample, example from a PICC line, from a patient with a PICC line in, you can't collect from that side. Incorrect tubes, wrong tube, again, could be the wrong anticoagulant, and the anticoagulants are indicated so that the analysis of that assay is correct and appropriate for that assay. And then the last one is hemolysis, where the red cells are destroyed and hemoglobin is actually spilled into the plasma or serum or fluid that that sits in that sample.
Okay, so here's our opportunity for a, sorry guys, for another voting. So you can do that via the chat line, you can do that via texting, as you hopefully know how to do that now, or via pollev.com. Same procedure, so I'll give a couple of minutes.
And this is actually about sample quality during the collection.
Yeah. So which sample quality problem accounts for an estimated about, that's high, 48 to 60% of specimen rejections. So has anyone got anything on the chat? I'm going to go with D, incorrect tubes. Oh, there you go, somebody else is going with that. Okay.
So we've got more E's than D's, and I think that's good because that's the correct answer. Hemolysis accounts for a lot of sample rejection, not only in the point of care space but also in the general diagnostic pathology space. And you can see on the slide that we have up now that in a number of studies that have been done, errors in laboratory medicine, the breakdown is in fact 54% of all pre-analytical errors are around hemolyzed specimens, 21% around insufficient sample, and 13% incorrect specimen collected. And I think it's important to know that you don't know if a sample's hemolyzed until you actually spin it down and have a look at that fluid versus the red cells. So it's important to understand the situations where you might be compromising the collection and you may have a sample that will give you erroneous results. And for those that don't know, hemolysis is defined as the rupture or breakage of the red cell membrane, and when that happens it causes the release of hemoglobin and other internal components into the surrounding fluid. That then affects a number of our analytes that we test routinely, and 2 of those are potassium and troponin, which are quite affected by any level of hemolysis. But certainly if it's a high level of hemolysis, you can see troponin levels falsely elevated. Sometimes they are falsely reduced, but the potassium every time is falsely elevated, and that's an indication of both renal issues and in some situations cardiac issues. So the treatment in those scenarios changes very quickly if a clinician is interpreting a result with a high potassium. It's a critical result. And we've got the list of we've got a few samples there that have been put into a centrifuge, and the plasma has been separated from the red cells. As you can see, the red cells at the bottom of the tubes, and the tube furthest left actually has no hemolysis. But as you move across, you can see from that the bottom ledger that it says the concentration of grams per deciliter of hemoglobin. And as you move across to the right, you'll see that the colour is quite dark at 1 gram per deciliter. You can still see through it, but the plasma is really red, and that's just rank hemoglobin sitting in that fluid.
So Judy, can I just ask a good question to either you or Point of Care? I guess a lot of the time there'll be some times where we don't use a tube, and we may use a syringe, and obviously capillary. So how do people identify hemolysis in a syringe? Is there a way of doing that? So for Point of Care, any suggestions? Or I guess we'll come to how to reduce hemolysis, but is there a way of identifying it other than in the tubes?
Yeah, look, that's a really important point, Julie, and there is no way to identify hemolysis apart from spinning down your tube, and in Point of Care we don't do that. So we just need to be really careful about our collection technique, make sure that we're following all the right steps and the right processes, and that will ensure we have a good sample to use.
Okay, that's a good point. Yeah, okay, thank you.
And a hemolysis of the sample, as I said, can lead to a biased result, either an increase or a decrease. That's not a true indication of that analysis. Possible misdiagnosis and possible errors for patient treatment or lack of treatment in the event where the result is actually reporting a value less than it should be. And in the other extreme, that very high potassium that's erroneous and not true. So to avoid the errors, the venous access is really important, and finding a good vein or a good collection area to perform the collection, following the procedures and following the procedures as they are in the green folder, and using self-filling syringes to ensure the correct volume, when that ensures we've got the correct ratio of blood to anticoagulant. Don't massage or milk the tissue. If you've got a poor venous access and it's a difficult collection, you will end up with some hemolysis. So you really do need to be mindful of that during that collection procedure. And also, once the blood is collected, mixing those samples appropriately, because if you shake the sample, you will cause hemolysis. The red cells are not they're not terribly robust. They are sensitive to temperature, they're sensitive to shaking, so you really do need to be mindful of how you treat the sample once you've collected it as well. And this is a true case study where we've got a man that's got multiple medical issues with cardiomyopathy, chronic kidney disease, arterial fibrillation, type 2 diabetes, and he's presented to the ED with a new onset of generalised weakness. The ED physician, as quite often in the ED setting, would order some renal functions, and when he did, the serum potassium came back at 7.4, which is a critically high result when the normal range is 3.5 to 5. The laboratory, in that situation, because this was a sample that went up to the laboratory and they would spin that sample down to do the testing, noticed that it was quite hemolyzed and that the result was in actual fact incorrect. But in the situation of a point of care setting, there would have been no way of knowing, and in that clinical setting also, the patient, there may have been some consideration for treatment that was not required in this patient. So from today, I hope we've sort of been able to cover some of your queries or give you some information that you might not have been familiar with before. But the big take-home message is correct pre-analytical procedure means correct result. So a pre-analytical procedure, if it's correct, we end up with an analytical procedure, and the analytical procedure is when we actually present that sample to the instrument. And to achieve that, there's all of those components as you see on the screen. You need to identify that patient correctly. You need to ask the questions correctly so that the patient answers you with their name and their date of birth. And if you can't do that, you need to identify the patient in other ways and actually ask someone if there's no identification on that patient, which sometimes occurs. Don't just assume that Mr. Smith is sitting in the bed in bed 3 because the board says Mr. Smith's sitting in bed 3, because we all know how chaotic some of the wards can get and things do change. Follow the appropriate collection procedure as outlined in your green folder. Ask questions if you're not sure. You've got point of care coordinators that are happy to help you with advice and recommendations. Always label the sample. If you're moving the sample away from the patient, you need to label the sample, and if that's with a sticky label, that's okay, as long as you've got identification on that sample that you're moving away from the patient, because there's always a risk that someone else will pick up that sample, someone will take it off you, or some scenario will occur and the wrong patient ends up in the EMR. The patient's results are incorrect for that particular patient. The best rule, if you can abide by it, is if you collect a sample, you are responsible for analysis. And finally, analysis of the best sample will give the correct result, and so provide the correct patient with the best patient care.
Okay, so I just want to thank Judy very much for her time, but what we'll do is firstly open to the coordinators to make any further comments just regarding probably those focused areas of patient ID and hemolysis, but if there's anything else you want to add, that's fine as well. We've got a little bit of time to do that, and then I'll just open the floor to anyone else who has questions. You can, if you don't have a headset, you can actually use the chat room for any of your questions to Judy or point of care. Otherwise you can just unmute your line and ask the question directly of Judy or any of the point of care team. So away we go. Is there anyone that has any questions? Maybe not. Point of care team, is there anyone that wants to add anything to the presentation in terms of information? I'll just make a brief comment for some of our devices that I think we need to be even more diligent with checking the patient information, because quite often our devices don't necessarily have patient verification where you literally have to verify that information. So if you're scanning a barcode for a patient that's the incorrect barcode and the information comes up on the screen and you don't check it and go, is that right for that patient that you're expecting the sample to be for, then it will go directly into the LIS and to the EMRs. So even more so for point of care, we really do need to be diligent with checking it in all stages, I think. So so that's just my take-home message to everyone as well, particularly for point of care devices over and above blood gas machines, which I think do verify the sample.
Is there someone online that wanted to ask a question?
Okay. Great. I know all the answers.
Okay, that's good. Don't forget to fill out the feedback and provide any additional information about things that you would like covered in this pre-analytical space, because there's plenty of things that we can always cover relating to point of care.
That's true. So just a reminder to everyone that we will put the recording onto both our New South Wales Health Pathology website and also onto HealthView. For those who access HealthView, we'll get the coordinators to send out the links for those in the next few days. You will also get a link to some feedback, as Judy mentioned. So please take the time, it's only a few minutes, to fill that out, and you've got an opportunity to also provide some input to future topics that we can run with these webinars as well. So I guess thank you for everyone on the line for attending, and big thanks to you, Judy, for your time this afternoon to present that. So, yeah, and I think we're happy to share the presentation as well if anyone would like just the presentation. Okay, so thank you everyone.
Thank you.